All right, we're rolling right on through the airway and breathing course here. And so here are some tools and techniques that looked really cool on TV when Johnny and Roy tried them, but you just don't need them very often. This is plan B probably. Plan A is going to be direct orotracheal intubation under visualization. You've seen it and you've placed it in the cords, placed the tube in the cords, and so whether you're doing DL or VL, you're visualizing where it goes. And then there's some cases where you would not be able to see, and you can't get your bougie to work, and so you're stuck with this blind intubation stuff. I really think the first two, nasal and digital, it wouldn't hurt my feelings if we never used those. But it's good to have a tool in your toolbox for that weird case where you need it. But nasal and digital really don't amount to much anymore. I think the salt's a pretty cool tool. But let's talk about nasal here real quick. All right. So it's rarely appropriate, and the patient must, in capital letters, be breathing. If you're trying to nasally tube someone who's not breathing or has agonal gasping breaths, it's a recipe for failure. Maybe you would use it in a case where the jaw's clenched or wired shut, and in the wired shut you don't have any options. In the clenching, you might have sedation or paralytic options. But if you don't, and most services don't, maybe it would be a tool for that. Maybe with some horrendous oral trauma, gunshot in the mouth, or some other baseball bat to the face, or some horrendous thing. Maybe in some weird entrapment where you can't get normal access. I don't know. But if you've got RSI, you're probably not using this. In the deep dark past, we used it before CPAP became available. We used it in those CHF, COPD, or those respiratory failure patients that were worn out, but they still they still had a gag reflex. They still wouldn't let you in their mouth with a laryngoscope. So we'd try to go in through the nose and intubate them before they absolutely quit breathing. Now with CPAP, we're not having to do that as much. So I don't know if you're ever going to need this, but here's how you would do it if you were going to do it. You definitely want the endotrol tube. It is softer, more flexible, and it has the trigger tip. You can see that in the top picture on the right. You definitely want a BAM whistle attached to it. That's the red device that's attached to the top of that ET tube in the top right picture. It's a BAM whistle. What that does is it amplifies the sound of their breathing. It lets you hear their breathing better. Amplifies the sound of their breathing, because what you're going to do is place this tube in the back of their pharynx and then try to time their respirations. And as they inhale, that's when you're going to try to pass that tube. The trigger allows you to direct the tip more anteriorly, which you will need if you're going to make a nasal approach. In the nasal intubation bag, a couple of nasal airways, probably a couple of sizes, maybe 3 or 4 sizes. I'd like to use one that's about the right size and then try to go with one a little bit bigger. So you take the one that's about the right size, you place it, you remove it, and then you go in with a little bit bigger. And you're doing that in order to kind of open up that nair, as well as a lot of services will let you put some numbing gel on there, a lidocaine paste gel that will numb up that nose and maybe even numb up the back of the pharynx a little bit. And then some services also let you use a vasoconstricting nasal spray to help you with the nosebleed issue. So there's 2 or 3 steps. Remember, this patient's breathing. They are conscious in some way. At least they're not unresponsive. And, so this is not fun for them either. But these are the tools that you would need. And you probably ought to have these together in a kit ready to go. The endotrols you don't use for normal intubation, so you might as well get all that stuff together. Your technique, use that NPA with some numbing gel, put one in, and then pull it back out, put another one in maybe if you can. Got to let that numbing gel work a little bit. It doesn't instantly numb up. It takes a few seconds for it to really have any effect. You insert your ET tube into the posterior pharynx through the nose with a BAM whistle in place, and now you listen for inhalation, and that's when the cords are the most open, and so you got to kind of time it. It's helpful if your guy's breathing at a reasonable rate, although I'm not sure why you'd be doing this if he was breathing at a reasonable rate. So you listen, and then you insert while you pull on the trigger, and that displaces the tip of that tube anteriorly, helps you get where you need to go, and you bury it. You place it fully in until the ETT adapter is at the nose. Take your BAM off, get your capnography on there, and do your usual thing. My problem with this personally is that I tend to push on that BAM to try to advance the tube, and I block the whistle noise. So, but we'll play with this in lab and let you see and play with this a little bit. A rarely used technique.